Welcome to Population Mental Health. This is the first lecture of this subject, PY2018, focusing on population mental health science. This lecture based on Professor Dodge and Collis' publication titled Population Mental Health Science, Guiding Principles and Initial Agenda, published in American Psychologist in 2024. This subject is actually established by the inspiration of this paper, and the paper provides foundation of the discussion of population mental health, and it provides background of population mental health science, bottom-up scaling of evidence-based intervention for individuals, top-down community level interventions, and also provide a very clear guidance about tasks ahead. As students studying psychology as well as mental health and other relevant subjects, you may realize that there are lots of psychological interventions developed by psychological clinicians and researchers to address mental health issues, and also lots of trials, for example, randomized control trial, clinical trials, have demonstrated the effectiveness of the interventions. However, for those interventions, mainly focus on providing interventions to individuals or individual families, and which means that many people in need or suffer mental health have not received any professional treatments, and let alone evidence-based program. So this is a big call for us as psychologists or future psychologists or people working in mental health field, that the individualized interventions have not been sufficient in addressing mental health challenges at a population level. What we need is to develop mental health programs as well as initiatives, policies to address mental health at a population level. As such, there has been a call for paradigm shift, moving beyond the delivery of sound psychotherapies or intervention program to a small number of self-selected individuals, and moving towards a population level to address a global crisis in mental health. For example, when people enroll themselves into an intervention or a psychotherapy, it's a self-selected process. If they don't come forward themselves, then they would not be able to access the intervention. And so we would like to see the paradigm shift to a populational intervention. Everyone have the access, have the even free access to address mental health issues they are facing from a community perspective or a population level. So very often we have the terms global mental health, public mental health, world mental health, community mental health, and population mental health as well. We choose population mental health so we can see that it's not focused on geography, such as US global mental health, and is different from public health perspective, and also it's more focused on population level. This paradigm shift is significant because instead of starting with individual therapies, the paradigm shift is to start with the population problem and work backward to solve it at the population level in whatever ways is effective and cost beneficial. Because in different cultures, when we talk about population mental health, we absolutely need to consider cultural impact of on mental health. And in different cultures, the understanding of mental health is different. So when we talk about the population level of mental health, we need to consider the cultural perspective as well. So this is why we talk about it in whatever ways is effective. There is no one size fits all. And we may have, even though we talk about population level, but it still has significant difference in different cultures, in different populations. There are different ways to address mental health at a population level. The first is the bottom-up scaling of evidence-based interventions for individuals, which means that we already have the interventions that have been demonstrated they are effective for improving mental health. But they are individualized interventions, so always focus, for example, one-to-one intervention or consultation, so the effectiveness is not scaled up. What we want is, from a population level, is that we can scale up the individual intervention so that more people can access the intervention, for example, from individual therapy to a group therapy or community therapy, so that we can invite more people to join the intervention. Scale the effective individual interventions to the full population through contextual and cultural adaptation. As I mentioned previously, cultural adaptation is very important because different populations have different understanding of mental health. We cannot scale up individual therapy without considering contextual and cultural contexts. For scale up, particularly from a health economy perspective, scale up is more effective for the population. However, scale up often receives some decreased effectiveness, what we call a scale up penalty, which means the decrease in effectiveness when a small evidence-based program is scaled up to a large population. Why? Because reduced accountability in implementation. Yeah, because the population, the target population, target participants are bigger. Then people work in a group, maybe the accountability in implementation of the evidence-based program may be reduced. And also insufficient funding. For example, nowadays that the governments in the world across countries often fund individual therapies but not community interventions, which means a scale-up evidence-based intervention may have insufficient funding to support the scaling up. And also inadequate training and ongoing supervision. For example, what kind of training we should provide to the facilitators or to the therapist, and what kind of ongoing supervision should be provided to the facilitators and therapists in a group intervention or providing intervention at the population level. This is important issues as well. And also professional labor market failures, because in the current training system, psychological intervention training or psychotherapy training more focused on individual interventions, individual therapies. And so how we can develop workforce to provide mental health intervention from a population or community level is an issue we are facing as well. Another issue cause scale-up penalty may be cultural mismatch between an intervention and the new population. So very often intervention develop in Western countries when the intervention is promoted or adopted in another culture. For example, in Eastern cultures, Eastern countries, then the intervention may not work well for Eastern cultures. So this requires research to provide evidence to support what kind of adaptations needed, what kind of amendment, modifications are needed for a particular individual therapy when it moves towards a population therapy. In order to scale up individual therapy or intervention successfully, we need to consider to integrate implementation science into practice and research. For example, how to translate research into practice, how to provide evidence for the practice, if the practice moving from individual level to a population level. And also we need to consider to invest novel intervention delivery systems, for example, online delivery, mobile apps, AI, machine learning as well in mental health, so that we can move from sitting in a consultant room to more technology support delivery methods. And also advanced alternate provider delivered interventions. We mentioned previously that the shortage of workforce in mental health is a big issue for population mental health. So how can we look at provide alternative providers? For example, can we train nurses? Can we train social workers? Can we train physicians or medical doctors to deliver mental health program, mental health intervention from a population level, so that we can have more people to support population mental health? And also we need to consider embracing culturally informed adaptation. As I mentioned previously, for some intervention, it may work well in Western countries. And also all the delivery methods, curriculums, and are based on the gold standard from a Western perspective. So how can we adapt these gold standards to different cultures? Is something we need to consider. So we need to open up the adaptation of the program in the training as well as in the assessment and intervention methods, and every session what to cover, and also how to reflect the cultural concepts in a specific culture. So these are the principles we need to consider, and also the strategies we need to consider when we bottom up scaling of evidence-based interventions for intervention to a population level. The shift from individual mental health to population mental health opens new opportunities for interventions that would be too expensive if applied only to an individual. For example, for many individuals in need, they would not go to psychotherapists if there is no government subsidy, because it's too expensive. People cannot afford it. So if we have the population mental health, then the cost for an individual will drop dramatically. Then it becomes affordable for individuals. And also it opened up new avenues for policies that could have indirect effects through cultural change. Policy is always important for population mental health because it can provide fundings to the community level intervention. This is what we call top down. Previously, we talked about bottom up, and we have the individual therapies. So we move from the grass level to the population level. It's the bottom up. But now we would like to look at top-down community level intervention with support from the policy, support from the government. There are challenges that top-down community level interventions are facing. One is funding diverse population-wide ways to increase adaptation of community-based intervention. This is something is very challenging. For example, in the photo, that's the mindfulness retreat we run for a veteran and the public. The idea was started with the intervention we delivered to veterans using mindfulness-based stress reduction program. And we found that that's an 8-week program. And during the 8 weeks, the program was very well. And we can see, for example, more smiles in the veterans. They open up to share their emotions and their experience as well. However, when we invited them back 2 months after the intervention, we found that the effectiveness disappeared. Why? Because people are facing lots of commitments, have lots of commitments in their everyday life without a facilitator, a teacher, or a therapist to support them as much as during the intervention. People drop down, people drop out. And so, based on our participants' suggestion, we organize Mindful Warrior initiative. Every month, we invite people to come back to practice mindfulness together once a month. And every year, we organize the retreat. This is the retreat in 2025. And you can see we have lots of people joining. But we also found because people's level of mindfulness practice are different, sometimes we found within a very diverse population, we have veterans, we have international students, we have clinicians, we have general community members. And so the population are very diverse. Then we found that we actually need to adapt the mindfulness intervention so that it can be applied to diverse population. It's very challenging, but we are getting there because we organize feedback sessions, asking people to give us feedback what to improve, and also what kind of practice they like, what kind of practice they found challenging, so that we can tailor our program to this diverse population. Another challenging is the monitoring at the state and national level. For example, the engagement in the intervention, and how can the state or the nation or the government to monitor the engagement of the intervention. Because it's a large scale, sometimes it's difficult to monitor. And also whether any intervention designed to scale up activity is in fact improving adaptation, adoption. For example, how do we know if the adaptation's effective? And whether it largely depends on the facilitator. For example, for us, we invite our participants to give feedback to us from time to time so that we can improve. Then how many facilitators, how many programs are doing this? It's difficult to be monitored. Then how to increase application and also encouraging people to participate, to practice, to improve their mental health. One is institutional support through the lifespan. For example, schools, universities, workplaces, community groups. For example, we deliver a mindfulness program to schools in a regional Australian city. And we found school support is very important. So we work with local schools, organize the intervention during the school time, during the school period, and the schools adopted the intervention into their curriculum. So this is important. And if the institutional support is sufficient, is strong, it often works quite well for population mental health. And also technology. For example, apps and wearable devices such as wristbands, smartwatches may help to promote people practice to improve their mental health. For example, if we have a smartwatch and then we often monitor our movements, how many hours movement, and also how many minutes exercise we have done during the day. So this technology is supportive as well. And also access to activities and policies to foster the interventions. So for some activities, and maybe we can integrate the mental health intervention, for example, a short mindfulness intervention at the beginning of a meeting. And also policies is important as well. We talk about that. When we talk about top-down community level interventions, we need support from the government, local government, state government, federal government as well, so that we have sufficient funding and have some policies to support the adaptation of the intervention. And also we can mobilize other domains of influence, for example, incentive for participation, and also promotion by influential celebrities. And for example, in our retreats, it's free, and also we receive fundings from hospitals as well as Mental Health Week, Queensland Mental Health Week. So we provide free intervention, free retreat, as well as a barbecue. And also free coffee, so people can enjoy their coffee and also enjoy barbecue together after the retreat. So this is the incentive for participation. From what we have discussed, to promote mental health at the population level, we need system transformation. For example, the effective primary care in physical health was very well, including first contact care, continuity of care, comprehensiveness, and coordination of care. However, there is a lack of comprehensive system of primary mental health care. We have primary care mainly for physical health, but there is no comprehensive system of primary mental health care. So there is a need to set up a universal system of primary mental health care for families and individuals and communities so that the system can transform to support mental health at the population. To promote population mental health, there are challenges. So there are tasks ahead. What are the tasks? First, scientific creativity and discovery. If we want to adopt individualized intervention to a population level, we need scientific support. We need scientific evidence. So the discovery of the way to adopt individual therapies to a population level, we need more research. And also we need rigorous intervention, evaluation. Sometimes gatekeepers block rigorous evaluation. For example, we have a co-ed program. We delivered mindfulness intervention to school kids, to high schools, and we would like to have a rigorous evaluation so that we can see from, for example, we enter the classroom to deliver the mindfulness intervention. So we would like to see at the classroom level, at the school level, whether it's effective or not. However, even though we received the university's ethical approval, we could not go through the higher level of the gatekeepers, the higher level of educational institution, even though the principals of schools were very keen to have the evaluation, but we receive a straightforward no from the gatekeepers. So we could not conduct a rigorous evaluation. So what we did is to use interview to do the qualitative evaluation. So the participants, the school kids, reported that they improved their mental health. They found they were calmer. They found when they're facing the stressful situations, they were able to take a couple of deep breathing to calm themselves down. And also they could managing their physical aggression so that it will not burst out, the anger would not burst out. So we have the alternative evaluation, but it's still a regret that we could not do a quantitative evaluation. And also community accountability as well. We need community support if we want to scale up the intervention to the communities. We need community leaders' involvement. We need the entire community to support the interventions. And of course, health economy analysis important to see the cost and the effect, and what is the cost, and whether the effectiveness to the population, to the number of participants increase dramatically compared to the individual intervention. So these are the tasks we are facing. And also I hope after studying this subject, population mental health, you would contribute some of the perspectives, some of the tasks to promote population mental health. Finally, before we close this lecture, I would like to present some final take-home messages. The first one is scale up evidence-based program. And as psychologists scale up or clinicians scale up evidence-based programs, they must be held accountable for population level reach, high fidelity to the protocol, and attention to the cultural and public context. And also innovate and evaluate population level interventions. And we must create and evaluate novel population level interventions that improve community, schools, neighborhoods, mental health. And also create a primary system of care to promote mental health and well-being, and to create a novel system to provide primary mental health care needs collaboration from clinicians, communities, families, and governments and policymakers as well. So these are the final take-home messages. Thank you so much for attending this lecture. If you have any questions, please feel free to email me at wendy.li@jcu.edu.au. I will put this lecture on YouTube, my channel Beyond the Classroom, Open Teaching and Learning. So if you would like to watch the video again, you can follow my YouTube channel. Thank you so much.